Stanford University.
I'm going to do the final presentation before the breakouts, and this is going to be a treatment update for mood disorders. And these are my disclosures. So the fact that certain individuals are active collaborating with industry, it's both a strength and a limitation, okay? So limitation is because I've invested in getting, not financially invested, but emotionally invested in doing research and getting research contracts from industry and things. I want to see these things do well, I guess, you know. On the other hand, if you don't have that experience of being part of the development of the new treatments, it's a little hard to have expertise and be informed. So one way of becoming an expert is be there for the whole story. Okay, so most of the things that are FDA approved, our group has been involved with in some way, probably most crucially being sites in multi-center trials for either FDA registration or for what they now call comparative effectiveness research. So if you have things that are already approved, well, how does A compare to B? So I'm going to have a look at the current approved treatments and talk a little bit about risks. And one of the things our group has become more interested in with time is looking at risk-benefit analysis, or benefits and harms is another term they use. And so the way the biases are set up amongst providers, they probably overestimate the benefits. Because, and the reason, this is not, it's not a bad thing to have an optimistic provider, okay? And the reason they overestimate the benefits is what they look at when good things happen are the results of the interventions, but also the placebo effect, or just the tendency towards health over time. Consumers, on the other hand, probably overestimate the harms, okay? Because anything that's bad that's happening, okay, it could be related to depression if you're putting on weight or sleeping too much or something like that, or it could be the medicine. So we have a creative tension between consumers, which probably overestimate harms, and providers who probably overestimate benefits. And as long as you're both aware of that, then you can bring different things to the table in working on problems. Okay, so it doesn't need to be some kind of a conflict. In fact, having complementary attitudes to things often make teams more flexible and more dynamic. So I'll talk a little bit about medication side effects, and then we'll look at some emerging new treatments. So why is this important? Well, I don't have to tell you guys. So mood disorders are common. There are serious consequences. The current treatments can help, but they may not work well enough, or they may have side effects. And new treatments can offer hope, as they may work better or have fewer side effects. Okay, so a lot of this is benefits and harms, right? So this is a slide from Dr. DiBattista looking at the history of medical treatment for depression. So I'm trying to be even-handed and talk about the unipolar stuff too. But basically, in antiquity, there were theories that, so melancholia is black bile, that there were substances floating around in our bloodstream that made us feel different ways. Today we call those hormones, okay? So it's not exactly the case that black bile does this, but it could be cortisol or it could be something else. And so over time, that kind of thinking of there being a biological component to moods or depression took root. There weren't really effective physical treatments until the last century. And actually the first treatment that was really effective was probably electroconvulsive therapy. And of all the other things that they've tried since that time, it is probably the only one that has withstood the onslaught of other things coming up that have been better tolerated and perhaps more effective. Lithium, first paper published in lithium was 1949. Okay, it's number 3 up there on the periodic table. See it up there? Okay, it's about as simple medicine as you can get. It's an atom, okay? The tricyclic antidepressants came out in the 1950s, and as somebody who studies bipolar, I'd probably put the first generation antipsychotics came out at that time too, okay? This was followed by the so-called monoamine oxidase inhibitors, or MAOIs, in the 60s. Okay, these are medicines that you can't eat cheese when you're taking that medicine. Then in the 1970s, a sort of dinosaur generation of in-between generation incremental attempts at improvement in antidepressants. And these include amoxapine, which used to be known as Ascendin, and meprodoline, that used to be known as luteamil. They're sort of forgotten medicines now, but some individuals who don't respond to the really, really old ones or the newer ones may respond to these in-between ones. And then famously, the serotonin reuptake inhibitors that really changed everything, because finally they had medicines for depression that didn't have side effects that were worse than the depression itself. Then refinements on these medications and new types of medications that involved looking at either serotonin or dopamine or norepinephrine. Okay, so three main chemicals that they worked on. And then most recently, neuromodulation, which I'll describe in a little bit more detail. So in looking at the treatment of depression, you would imagine that antidepressants would be important in the treatment of depression, and indeed they are. They're the foundational medicines. This is in contrast to what's going on in bipolar disorder, where antidepressants may be an excellent idea for about 1 in 7 people with bipolar. Okay, so that's not a foundational treatment. It's not like we're so flush with great treatments we can toss out something that works really well in 1 in 7 people. Okay, but it doesn't hold that same foundational space that the antidepressants do in major depressive disorder. There have been various over-the-counter agents used to treat more, in general, milder cases of depression, perhaps the kind of depressive symptoms that fall a little bit short of full-on depression. And these would include SAMe, which in fact can cause switches into mania, so you have to be careful with that. But St. John's wort, which in fact has drug interactions that can influence levels of other medicines. So it's not to say that these things, just because they're over the counter or are nutraceuticals or natural treatments, are completely innocuous. Okay, but by and large, they don't have a huge side effect burden. There are non-medication interventions. We talked today about psychotherapy some. There's also light therapy, exercise. There are devices, and we'll talk about that a little bit later on and give you some example of some of these devices that are available. If we move on to bipolar disorder, so this is the way things are set up for bipolar. It's a little bit more complicated than unipolar major depressive disorder. The approvals for unipolar major depressive disorder are for acute depression and for prevention of depression. And the general strategy is whatever worked acutely, it's got a pretty good chance of working in prevention. Kind of makes sense, doesn't it? And so what's different about bipolar is you've got acute mania, you've got acute depression, and you've got longer term treatment, and you could look at not only prevention of mania, but prevention of depression. Okay, and so Jennifer Culver showed some data on CBT in prevention of both mania and depression. So you can see the years in which these different treatments were FDA approved, and really there wasn't a lot going on until around the time I came to Stanford, which was lucky for me because I was interested in this kind of stuff. And so when I came to Stanford in 1995, divalproex had been approved, and it was basically the 3rd medication approved for acute mania. Okay, so there was lithium, chlorpromazine is thorazine, right, an older antipsychotic. And way over on the right, lithium was also approved for maintenance treatment. And they went through a period where lithium was the real preventive agent. And if you really wanted to treat mania, you used antipsychotics. And if you wanted to treat depression, you used antidepressants. but antipsychotics could prevent mania by causing depression, and antidepressants could prevent depression by causing mania, so they weren't considered really mood stabilizers. Okay, so that was the way things were kind of circa about 1995. And then you can see this explosion of drug development in the 2000s. So most of the things that are on this slide were FDA approved in the 2000s. Has it slowed down a little bit? It has. Okay, so it slowed down a little bit. There's a few very interesting things that I'll share with you in a couple of minutes that indicate that we're making some incremental progress with some newer treatment agents. But this basically was a mania of drug development in the 2000s that has slowed somewhat now. Okay, on the unipolar side, there's been a shifting of emphasis towards something called neuromodulation that I'll talk to you about. Maybe a little bit less so on the bipolar side because we still have some medicines filtering through. What you see there in the first column on the left are primarily antipsychotics and anti-manic agents that are lithium or anticonvulsants. In the middle, a huge unmet need, bipolar depression, only 2 approved treatments. And on the right, the longer-term treatments that are approved, all of them have an acute indication with the exception of lamotrigine or Lamictal, okay, which has a maintenance indication but no acute indication, okay? So side effects, medications, you can go on the internet and get the prescribing information. You can see box warnings on things, okay? And so these box warnings are potentially serious adverse events, and everything that's FDA approved has box warnings, okay? The FDA has gotten very interested in suicidality, so the asthma medicine Singular has a warning for suicidality. 11 anticonvulsants have a warning. All of the antidepressants have a box warning for suicidality, and that's in individuals who are less than 25 years of age. That's a very important qualification. So the majority of individuals in that younger age group will get a decrease in suicidality, but there will be a small subgroup that gets an increase. Okay? If you're between 25 and 65, it doesn't make any difference, and if you're over 65, there's a net decrease in new onset suicidality. Okay, so a very important age effect on that suicidality warning for the antidepressants. The so-called atypical antipsychotics also have box warnings, and I want to share with you this particular schema. So this is a way of looking at the different medicines. So if you look at the right-hand side of that, you've got antidepressants at the bottom, then mood stabilizers, then second-generation antidepressants. So broadly speaking, now I'm talking side effects, okay? The side effects are the least with the antidepressants, a little bit more with mood stabilizers, and higher still with antipsychotics. Then you can see over on the right, these are rough estimates of how much extra side effects over placebo you get, okay? So low would be less than a 5% bump, medium a 5 to 10% bump, and then high would be more than a 10% bump. So even if you're looking right at the top of the pyramid, it doesn't mean that you're destined to get side effects. You just have to be more careful because there's an increased risk. Okay, and so the tolerability first approach, which I think a lot of consumers and for providers would embrace, would be to start at the bottom where there's fewer side effects and only go to the top if you had to, right? So what would derail that would be probably clinical urgency. So if somebody has psychotic manic symptoms or something like that, you would probably want to start higher up on this, okay? And so just to touch very briefly on what's out there, there's Vilazodone or Vibrid has now been approved for major depressive disorder. It's not approved for bipolar disorder, okay? So it's a different sort of medicine. And then completely unapproved, so that it doesn't even have a trade name yet, is Cariprazine. Okay, it'll probably get approved in the next 12 months for acute mania. Okay, and it's you could look at it as a refinement, if you like, of aripiprazole, Abilify. Okay, And then 2 medications. We only have 2 medications approved for bipolar depression. We're probably going to have 2 more approved in not too long. Okay? One of them is already approved as an antipsychotic for schizophrenia called Latuda or lorazepam. Okay? It's a little bit like an easier to take version of Seroquel. It's a little bit like that. And then the other one is armodafinil or Nuvigil, which is approved for sleep disorders, including obstructive sleep apnea, narcolepsy, and shift work sleep disorder. And this medication is, it's a refinement. If this is modafinil or Provigil, then the right-handed version is armodafinil. Okay, does this work just as well? Who knows? Okay, there's one controlled study. It's not going to get FDA approved because the patent's running out on it, which is, in some ways, that's very good because it'll get cheaper. In some way, it's bad because nobody's incented to prove that it really works. Okay? So Nuvigil, in 6 months from now, will be much, much more expensive than Provigil, generic modafinil. Okay, they may have comparable efficacy. That remains to be seen. But Nuvigil it looks like the one that's going to get developed. So there are other antidepressants, melatonin-specific drugs, stress hormone blockers, something that works on all 3 of norepinephrine, serotonin, and dopamine at the same time. Okay, so these are all in development. Maybe in the next year or so we'll see something new with that. There are some false starts, and I just want to just very briefly touch on the different types of neuromodulation. Dr. Salveson talked about this last year. There's electroconvulsive therapy, which has withstood the onslaught of all these medications. For some people, this is a really good fit. For other people, they don't tolerate it well enough. It involves expense, involves getting a general anesthetic and things like that. So it's a non-trivial burden. Vagus nerve stimulation is something where they put a stimulator inside the body and then it stimulates the vagus nerve. It was first FDA approved for epilepsy and is approved for depression, but is not generally covered by insurance companies. The effect size is not quite as robust. One of the things about devices, they don't raise the bar quite as high for devices. For most of the medicines, you have to beat placebo by at least about 10%. Okay? For devices, sometimes they'll give them a little wiggle room there. Okay? And so it's probably not as robust as some of the medication interventions. Transcranial magnetic stimulation is now FDA approved for depression. And again, insurance companies are not yet paying for this, except some places in the Northeast. And it's a somewhat pricey treatment, but it's better tolerated than electroconvulsive therapy. Okay, no general anesthetic, you're not having memory problems. It's probably better tolerated treatment. Maybe a touch less effective, but for some people it might make sense. In very treatment resistant, there's something called deep brain stimulation. With a lot of the brain imaging studies, we figured sort of where the mood and emotion processors are in the brain. The specific chemistry of what's going on to cause mood symptoms in those places is a little bit above our pay grade. We haven't quite got that yet. And so that in a simple-minded fashion, if you can interrupt a dysfunctional mood circuit, maybe then you can interrupt the symptoms. That's one way of looking at it. So without even knowing the specific biochemistry. And this is kind of stolen from Parkinson's disease, where they would cut certain fiber tracts to take away the trembling, the shaking. Okay, and obviously it's not a cure for Parkinson's, but it's a way to short circuit a problematic circuit. And so this has been used in mood disorders. It involves putting wires in your brain, a little bit not ready for prime time. Okay, still very much a research tool. One of the challenges was, well, how can you make that like less invasive? And this is something that's been developed at Stanford. Now we're down to like 4 patients treated. You know, the FDA has approved 4 patients to get treated for this so far. And this is something called radiosurgical neuromodulation, and it's a little bit like Botox for your brain. Okay, so what the FDA in its role to protect people doesn't want to be able to see any kind of scar in the brain anywhere. So they go into that same circuit where they interrupted it with the wires and just stun it. Okay, so they don't kill it, but they stun it with radiation. And in the patients treated so far, my interpretation of the data is that the improvement lasts for about 6 months and then gradually wears off some. Okay, so it's, you know, this is the kind of thing that moves at a snail's pace forward. Okay, but if that's the case, then, you know, well, can you retreat people? Do you want to use a higher dose and actually deactivate that area permanently? Those are all the questions that can be answered through this, but it takes literally years to get this. But if circuit interruption is going to be realized in a way that doesn't have surgery and hardware, it's probably going to be something like this. Okay, and so in conclusion, we've got common disorders, bipolar disorder, major depressive disorder. We've got medications that can help a lot of people, and if you fiddle around long enough, you can find something that is worthwhile for most everybody. We've got psychotherapies that can be used with the medications that can add value. And maybe a little bit more so in the unipolar and the bipolar area, this approach of neuromodulation has become a research focus, and hopefully with a few more years of this kind of research, we'll have some more effective treatments to offer people. Yeah, so this is a very interesting comment. Rather than let mental illness control you, you control mental illness. I think, you know, what Robert was talking about is like living with mental illness. You know, you could, even the choice of words, you know, in the DSM they use the term disorder instead of illness. How you choose to frame this. One of the things that disturbs me the most when I'm reading medical papers is when they talk about victims of cancer or victims of mental illness. And if you see yourself as a victim, in some ways that can become a self-fulfilling prophecy, right? You talk about people who are fighting cancer or living with cancer or things like that. And so I think the same holds for mental illness. The kind of medical struggles that are very common to pretty well everybody in the population eventually are not all that undifferent from depression and bipolar disorder. Okay, and so rather than stigmatizing these conditions and saying they're in some way different than having throat cancer or something like that, it probably is not a distinction that is all that helpful.
For more, please visit us at stanford.edu.